Hello, everyone, and welcome. I hope you're all having a great day 2 so far. And it is my pleasure to introduce our next speaker today. Next up, we have Nicole Neumarker, and she's the SVP of Research and Development at Cotiviti. And her talk today is entitled, Employing AI in Healthcare Analytics, COVID-19 and Other Predictive Use Cases. Please welcome Nicole to our virtual. Okay, Nicole, you can turn on your camera and join.
Hey, thank you, Morgan.
Okay, have a great talk.
Thanks so much. All right, I really appreciate everyone taking time to join my session. Good evening, afternoon, morning, wherever we happen to be. I'm in Utah. It's about 105 degrees, but thank goodness I have air conditioning. So we'll get right started. As far as agenda, I just things. We have a super concise talk today, and I'm really looking forward to it. These are a couple of the things I'm going to cover. So I'm going to talk about hype cycles related to both AI and healthcare and how we apply them at Cotiviti. I'm also going to go through some use cases, a COVID-19 use case, and then a couple that spawned off of that here at Cotiviti. And then I'm going to wrap up talking about how we approach our investments in AI and some of the ways we've thought about it over some pitfalls. And successes. So we'll talk about all of that. All right. The infamous Gartner hype cycle. This is one of my favorites. So given that we are in health, so this is a healthcare talk, healthcare and AI. I'm going to talk about healthcare, but healthcare, despite the fact that we do have peer organizations, finance and others with a lot of regulation. So some argue that, well, you don't get as much innovation or growth in healthcare because you're regulated. Well, finance is regulated quite a bit as well, but finance has a lot more consumer approach, consumerism relative to healthcare at this stage. And so often healthcare lags behind. I've worked in a number of verticals in my role as someone in charge of IT or technology, or I've had CTO titles and various titles throughout my career. And what I've found moving into healthcare is that healthcare doesn't quite move as fast. There's a lot more trepidation, a lot more legacy systems to deal with. And so when I look at the hype cycle and it's vertical agnostic, you kind of have to pick apart, well, where is healthcare? And for us, and I'm reflecting on some of the things we've experienced. We work with all the major large payers. We have relationships with providers as well, and our CEOs and MDs. So we really are steeped in healthcare ecosystems. I want to talk about a few of the things that have popped out for me when I was looking at this. Things that definitely are in play with us. GPU accelerators. Definitely, when you're talking about the kind of quantity of healthcare data that we deal with, and that exists in healthcare generally, and the constant accumulation of it, if you will, we've had to leverage GPU accelerators. We had processes and models that were running for days. So definitely that's an area we've invested in. RPA, robotic process automation software. This is one of my favorite topics. I kind of think of this as the Star Trek tribbles of AI. And I say that a little bit in jest, but not really, because they proliferate everywhere. You get a vendor who wants to enable robotic process automation, and you get a BU leader or a division leader or someone talking, and they talk together. It's like, oh, I can draw a lot of costs out of my business, and I can do it on these big monolithic legacy systems, and I don't have to replace them. And look at all the money I'll save. Usually, though, that money is acknowledged saved in that year, and you don't really see it as much over time. Plus, it's a nice little revenue stream for your vendors. But in the midst of that, you've basically put a legacy solution or a legacy process problem underground. And so as someone who wants to move us into a future state and integrations and interoperability, when you layer on automation on a problematic system, you're really just punting the problem down the road. So I have mixed feelings about it. There's definitely a time and place for it, but you can go down some difficult paths. So jumping ahead though, machine learning, auto ML, data labeling, we do a lot of data labeling. We don't actually pay for those services, we do it ourselves in-house. Auto ML is something we've been experimenting with very recently. Machine learning we've been doing for at least 5 years. And so I would say we're sort of all over as far as our maturity and whether these things are really hitting a plateau now or in 5 years. And then finally, NLP, cloud services PaaS. It's no secret that I think healthcare has been generally resistant to the cloud. I know when you're, and really, I mean, for all our sakes, we don't want PHI leaked out. It's bad enough. I mean, I get so many notices on just my email being leaked out of the cloud applications, at least 10, it seems like a month. So it is very important. It's reasonable that payers are very judicious about decision making and putting data in the cloud. And I think the cloud providers, realizing that they want to engage in healthcare, have had to step up their game in high trust certification and much greater controls as far as how we certify that something is truly PHI worthy. And so I think we're just now, it says 5 to 10 years. I think I've seen payers, we do quite an amount of cloud work as far as our analytics. And so in that way, I would say we're finally kind of getting to the place where we can now compete with our peer industries. And finally, NLP, we've been talking about NLP and healthcare. Actually, I feel like this one for healthcare is probably more on the plateau than 5 to 10 years from now. Trying to draw data out of medical records is something it's been the holy grail for healthcare for a long time, and we've also at Cotiviti made pretty significant investments there, and I'll talk a little bit about those later on. All right, so now let's overlay that to healthcare. And with healthcare, now there's a whole different series of, now we're getting a perspective of where is technology relative to healthcare and investments, starting with the strategy. Do you have your AI healthcare strategy? I've seen strategies evolve. I don't think of this as a binary thing that a strategy is in place. You lay down some strategy, you iterate that strategy, you adapt according to the value and the investments. We'll talk about that also a little bit later. And you make decisions as you go, and don't be afraid to let go of a strategy that's not working. 2 to 5 years. APIs, when I first was working with some of the larger payers, trying to build APIs, it was considered sort of, okay, well, I guess we're ready for that. But really, it's been sort of the foundational work that'll lead us to greater interoperability by getting our feet wet in comfort level with lean APIs, data interoperability between intermediaries like us and ecosystems outside of us. And so we've been investing a lot in that over time. It's pretty standard for us now. RPA, I talked about, cloud, I've talked about. I'm going to skip over the 5 to 10 for a minute, and I'm going to go to the greater than 10. So blockchain, my other favorite thing to talk about, not really. I mean, it gets talked about a lot, almost as much as COVID, not quite. So blockchain, in my mind, blockchain generally is the technology itself. Blockchain, ledger technology, is not complicated technology. As someone who has to manage engineering teams that build massive enterprise systems, blockchain isn't difficult technology. I can hire those developers. What is hard is the consensus and the collaboration and the decision making of what gets put into that centralized record, what gets taken away, who's allowed, who's controlling it. As soon as you start taking data out of a walled garden of sorts is when everyone starts to get nervous. And as I've seen blockchain evolve and kind of rise up and come down and rise up again, often it falls back to that it's that consensus required, just as we need that kind of consensus for interoperability. Blockchain is interdependent on that sort of collaboration. So I think, I believe it's time to stop thinking about blockchain mostly as a technology and more as what is the use case that we really are trying to solve collectively. Okay, so back to the 5 to 10 years. These are the areas where I would say Cotiviti really is making our most significant investment and doing the most work. And so not that I feel super ahead of the game, but I feel very pleased with where our organization has been and where we are today as far as where we're spending our time. So the first thing, a really critical investment for us is that healthcare data and curation enrichment. At Cotiviti, we call that Caspian Insights. When I talk about COVID-19, I'll talk a little bit more about that. But that is where we are taking all the data coming in from all our organizations and business units, providing a layer of abstraction and normalization and semantic understanding. And then we are, in essence, enriching it with social determinants of health and demographic data and anything we can get our hands on so that we can have some really meaningful analytics. And so that brings me to those other 3 bullets, which is once you've got a sense of the kind of data you can actually operate with, you can start layering on interesting technologies. This is where the cloud has really benefited us. We've had 2 different functions, I would say, that are addressing AI at Cotiviti. One sort of built up in the data center, took years, fine-tuned, get it all working, a lot of open source technology. And then a newer version with Caspian Insights where we're much more leveraging the cloud. We're trying to take cloud capabilities and not have to start from scratch with some of those open source technologies and really find a hybrid and best of both worlds. So with that, we've started to build more advanced analytics, and we've long had network value solutions as well as payment integrity solutions. Those are the things, those are in our DNA. And so what we're doing is taking those from the expert systems that they've always been, and the really complicated but validated metrics that we have, and we're evolving those into more predictive capabilities, and leveling up what we've been doing for years and years. So that's my general semi-hot take on the hype cycle. I alluded to this briefly. We have 2 tracks at Cotiviti. There was one track which was built almost as there are a lot of scenarios out there where you kind of build a lab. You build an AI lab and it sits adjacent to everything else going on in the company. And it's sort of, mad scientists and PhDs. And I think we started that way, but very quickly we decided that to drive value and to ensure that we had the right focused attention, we shifted the focus of that function into a more operational oriented AI and ML organization. And they report up now into a leader who really is focused on BPO improvements. He runs the part of our organization that has the most people. And so a lot of the AI and ML work that they focus on is how do we optimize where we have a lot of people involved and can reduce the number of people required to engage in something. A perfect example of this is our site prioritization for retrieval outreach. As an example, we take a bunch of data in around providers, when they're willing to return our calls, when they're willing to send a record, do they even return a call or do they prefer a fax? And we put all that data in and we manage algorithms that say, this is how you contact them, this is when you reach them, et cetera. And it's raised our retrieval rates immensely. So examples like that reduce our efforts in terms of call center volumes, but increase our overall quality of output. Then there's the fun part, the predictive AI and ML, which sits in our Caspian Insights organization in our R&D function. Again, it's not a lab. It doesn't sit off doing who knows what. It's extremely focused in trying to solve critical use cases that augment and enable better healthcare and enable our payers to have better insights and to have more accurate assessment of transactions. And so an example of that is the diabetes onset prediction model, which is a very recent model we've worked on, which we were able to take a whole bunch of data and assess not only when someone will likely have diabetes, but also if and when. So we have these trajectories that we can lay out, and that's been a really interesting use case for us. All right, moving on. Let's talk about COVID, because no one's talking about COVID. So I thought I'd talk about it today. And so Cotiviti, as I have alluded to, we have a huge amount of data. And when it was right around, I'd say, March, and the entire organization is trying to lift and shift from, we have a lot of remote workers, but we had a lot of people in offices. I'm trying to lift and shift my entire R&D organization, including the Caspian team. And they were like, wait, we just want to stay behind, work together in this office, and really see if we can provide value around the COVID pandemic that is now emerging. And no one seems to have good clarity on where it's happening and what the data is and who's going to get it next and where the hotspots are. I was like, okay, you guys can stay cloistered in that office by yourselves, working with remote workers. Everyone else moved home, and we've been working from home ever since. So if you recall, around March timeframe, there was very little predictive data. There was very little understanding of, we kind of knew it was in the West Coast. We knew it was coming in New York. We didn't know where else it was going to pop up. A lot of questions. And given the just sheer quantity of our data and how often we get data, it's a steady stream. we knew we could probably build a level of surveillance, and there's no revenue generation in this for us. It was fascinating and helpful, and it was collaborative with our communities that we work with, and so we embarked on this. And one of the first things we did in starting this effort was, what is CDC putting out? What are they trying to measure? What are some understood things at that time? And we know a lot more now. There's still a lot we don't know. But what did we understand at that time? And at that time, CDC had put out this pyramid of all the cohorts that they were measuring. And if you look at it from the bottom up, each cohort and each metric then is a leading indicator to the metric above. And ultimately, these metrics and these cohorts were being used to assess, are we or aren't we ready to open back up? I mean, remember, we're now just going straight into lockdown in March. When are we going to be able to open back up? We'll be able to open back up when we can start measuring these layers of this. It's a reverse funnel, if you will. So we always hear about the mortality rates and the hospitalization rates. These other layers below are really difficult because they are primarily decentralized in specific providers. The payers have it to some degree, but that's also segregated. And so we had this really unique opportunity to bring data together and look at it across these cohorts. And we started primarily with symptomatic, looking at ILI, which is the influenza-like illness. But I'm going to talk through each of these cohorts and some of the things we've been doing. So they also put out something called this signature care profile. And that basically said, look, these are the attributes of people we believe getting COVID today. It looks like flu, it's not flu. So we did a whole bunch of analysis of data to say, okay, where are we seeing transactions across the country where people are coming into the doctor with flu illness, but they're not getting diagnosed with flu? There's always a gap like that. Every year there's a gap like that. But how big is that gap? Is that gap bigger than it typically is? And when we looked at this data, it was almost as far back as, I believe we were seeing anomalies in December on the West Coast. And we know now that officially, I think some of the early diagnoses on the West Coast were in early February, maybe even late January. But so we definitely saw some anomalies, and we definitely knew that we should start digging in. So we did. And our theories around this were that the actual mortality rates are being underrepresented because there's a whole bunch of other cofactors going on that are causing people to be hospitalized, causing people to be to pass away, and without even really knowing that it was in fact COVID. And so began sort of this drill into these cohorts, and we were able. This is a later stage. If you go to our website today, we have two versions of the tracker. We have a tracker that focuses on where we think the pandemic's going to go next, and then we have a tracker that shows where we have these cofactors and these comorbidities, both internal and external and clinical, and why when you overlay those risk factors on top of the fact that there might be some latent COVID outbreaks happening, you in fact have a much greater likelihood of having a category of hospitalization that traverses and surmounts what you're able to stand in that particular state, that particular county. And so it's an interesting part of our website. You can go take a look at that. So we started looking at the cofactors, the comorbidities, and drilling down. And you can drill down as well on our site. And we started to look at each of them individually, because in any given state, there's different preponderances for these comorbidities, and there's different demographics. You might have a very young demographic who's less likely to adhere to care because they believe they're immortal, or you have older demographics, maybe retired demographics, that they are going to hold on to their process for caring for themselves, yet because they're older, there's more likelihood. So we took a lot of these factors into account, and we've created these heat maps in anticipation of trying to assess where are we seeing a lot of medically attended cohorts that will then lead into greater hospitalization and ultimately into higher mortality rates. All right, so down to the sort of second to last part of that platform, that pyramid. This is where we began our COVID tracker, and it was based very specifically on the influenza-like illness anomalies. And it was an interesting, scary, and fun project all at once, because if around this time in March, we were able to look at, okay, only a couple states are really talking about COVID in any meaningful way as far as outbreaks, yet everyone was preparing for it. I have an ER doctor who lives next door to me. He's like, it's like eerily quiet, is what he would say, and in the hospitals locally. And so what we did was we said, you know what? No one's talking about it in these states, but based on the data that we're seeing and these anomalies and these upticks and gaps between normal ILI, otherwise not diagnosed, and COVID, we think there's outbreaks here, here, and here. And we listed it out, and we waited, and we checked Johns Hopkins later, 10 days later, and lo and behold, about 80% of those states that were on our list that we thought were on the verge of an outbreak showed up as having suddenly a rash of cases and another rash of cases and another rash of cases. So it was fascinating to us, and we've been updating this tracker. This tracker you can also find on our site, our Cotiviti site. Super fun, scary, like I said, all at the same time, but it was a really interesting exercise that we did, and we've joined a consortium to help aid in different types of analytics, and we're on different tracks for that as well. And so finally in that tower, it is the infected asymptomatic. And this work that we've done around comorbidities and gaps and social determinants of health, it's all influenced how we are now as these new symptoms come out about COVID, and as we understand more about it, especially as kids are starting to go to school and their symptoms are very different perhaps than adults, sometimes not even very visible, inflammation and other things that aren't as obvious. We are starting to fold those into our data models and understand better how we can help continue to predict and understand where these outbreaks are going to happen. All right, we had a nice shout out from Forbes. It was very kind to them. So we really enjoy this work that we've been doing. And then because I need to wrap up in 2 minutes, shockingly, we have a fraud solution that we provide, but COVID, our CEO just did a webinar and he was alluding to this earlier today. With COVID, we do a lot of bypass of the rules and filtering and things that we do relative to claims as they come in. So we bypass a lot of the rules. We want people to be taken care of. We want to ensure that those with COVID are getting their bills paid and they're able to get into hospitals, et cetera. But with that, there is a lot of opportunity for fraud. And our AI teams, ML teams, definitely leverage higher order tools to really understand some of these schemes, highlight them, pick them out, and then they get implemented as more sort of general rules in our expert systems for payment accuracy. But this has been an interesting area as well that's emerged from COVID. I'm going to jump. Telehealth is another one, obviously massive jumps in telehealth. And so we're looking at that as well. We don't have any fraud detection quite yet, but this is one of the areas we're working on right now. And then lastly, I just like to end with this, which is it's very easy to spend a lot of money in tech and not get a lot of value. And what I consider one of the two most critical things, first being how you evaluate, having a really critical filtering process in place for how you decide what you're going to invest in. Number one, I do that no matter what vertical I work in, especially in healthcare. And then two, there's always the BPO and the operational costs we're trying to reduce to increase increase healthcare's availability, but really also looking at it through the lens of value and health value, and are we providing? Our CEO was just talking about how we're moving to a value-based care model in the future. It's coming. So understanding how we ensure great value in our solutions is a critical way we make decisions around what to invest in. All right, I thank you all for your time. I think I just got it to the end. Here's where you can find our resource center. It's on cotiviti.com /COVID/ just go to cotiviti.com. I swear it's the easiest way to find it. It's right there at the top. All right, thank you so much for joining.